Now we have the last presentation by Dr. Jayaraj. Dr. Jayaraj is from within, unlike the other three researchers who were from outside the department. Dr. Jayaraj is from within the department. I know him as he was the DPMO of Tumkur district, and I think that's where he's done his research. And now currently he's with KSAPS, and he'll be presenting on the analysis of the quality assurance program in Tumkur district.
Thank you, Dev, for giving me opportunity to present my paper in this conference. Good afternoon, everyone. This is the quality assurance program in Tumkur district in 2007 as a pilot project for 1 year and extended for the next 3 years. The background of the Tumkur district having a large area because it's the second largest district in Karnataka and having a large population, and also 10 districts with many number of health institutions, 140 primary health centers and 477 sub-health centers, and also having a large number of private sector with a medical college and nursing homes and general practitioners. My objective and methodology adopted is to critically analyze the quality assurance program which was run through over the period of this, especially in the reproductive and child health program. The methodology adopted was the literature review on the concept of the quality of care and also assurance. The description and analysis is based on my data collected, and also it is complemented with my field visits during this project, and also I have done a SWOT analysis, strength, weakness, and opportunities analysis of quality assurance program. This is actually we supposed to follow the cycle, quality assurance cycle, having 10 steps with in the plan and standards, set of standards and communications and other things. The Government of India has given the opportunity to do a quality assurance, especially in the reproductive child health, STA and RTA, and family planning, and immunization sector. So there was a training program and for the set of district team, and we have made a quality assurance cell at the district level, and this team has to undergo the training and has to visit all the health facilities. That is, in the beginning we have set 100 institutions and later expand to the other. The team go and visit the health centers in a fixed day and monitor the things, the observations and the verification of records, and recording all the according to the checklist given to the team. So identify the problems and set the priorities to solve the problems at the level of either at the facility level or at the taluk level or district or at the state level. So the tools adopted in this program is especially 6 dimensions of the World Health Organization. So those elements of the service environment, proper disposal of waste, access to the healthcare, equipment supplies, and professional standards and technical competency of the staffs, and the continuity of the care and integration of services, the client-provider interactions and informal decision and making privacy and confidentiality. Especially in these tools, so some of the clients-provider interactions and other things could not able to make during the visits because of the lack of the clients. These are the results of the visits and observations made We have done a gradings. The 100% grading is more than 75 is A grade, and 51 to 75 is B grade, and 25 to 50% is the C and D. So these facilities have been graded according to the checklist, and the total score of the facilities have been. In the first visit, we have done 2 visits in a year, first 6 months and second 6 months. In the first visit, 55 facilities have been assessed, and the scoring was very few facilities have scored A grade, that is not able to achieve the quality services, and B and C is, even D is only 2 facilities. In the second visit, after a visit which have been assessed in the first, they have increased, especially in the second visit. A grade and B grade have been much more than the first visit, and even D is 0 level. So the C grade has been reduced. So the facilities, they identified the problems have been, the solutions implemented at the facility level, at the district level, or at the state level. The percentage is also very less, as 68% at the facility level, and district level, it is 31%. So this applies to, this is almost all the over the period, it is the same. So the problems raised during the visits could not able to solve it. So these have been continued in the next visits also. The examples are the main, these are the building maintenance and cleanliness, construction of toilet for women, provision of equipments, and regular drug supply, training of medical officers like basic emergency obstetric and also anesthesia, ambulance and generators for the facilities, updating of the various records and amenities for the patient's comfort. And the analysis, there are the many strengths and opportunities also, and also weakness and threats also. We have a skill mix staffs, and availability of the standard guidelines and protocols, and the districts have a very good training center and adequate communication infrastructures of all the facilities except sub-health centers. We have a high turnover rate of around 16% at the district at the every year, and it's a poor regular supervisory visit because of the many meetings attended by the program officers, and around it is a 40%. No continuity of the training for QA program. Only 89 staffs out of 2,600 staffs have been trained. So there is no continuity in the QA program for the either for the doctors or the health staffs. And poor team commitment for the QA, no review at all, regular review, and poor feedback culture by the facilities. And there is a presence of many programs. So because of just what we are actually checklists done, most of the staffs have been concentrating on the, especially for checklists. When we go to the visits, so they prepare for the checklist, that's all, what has to be about. They did not concentrate on the especially process of the quality service delivery. So opportunities, we have got a very good financial support from the government, and also the decentralization of power and delegation of the power to the health centers. And we have got very good, especially in the Tumkur district, we have got a lot of non-governmental organizations, doctor association, and they are also very potentially supporting our system. And support from the HMIs, especially from the state, it is also was there. And community participation via health committee. There are a lot of health committees, especially. This community participation, there is a opportunity to take this quality assurance. And the threats we observed is the actually frequent change of the political and administrative leadership. That means there is these committees having elected representatives they have to go through the committee financial structures and other things, and the three-tie system, there will be frequent changes and also frequent changes of the district team leaders and district program managers also. We have to depend upon, especially from the outside dependency for the quality assurance training expertise. In the beginning of the pilot project, the training was conducted by the Population Council of India, and later it was stopped. So there was no continuity, especially in the training. So that was lacking, and a lot of nodal officers, especially this quality training, changed very frequently, and district program DHOs have been changed very frequently also, hindered this. Yeah. So we have the lessons learned during our observations. The value much more potential contribution to the regular supervisory, supportive supervisory. There is only supervisory visit, it is not supportive. And the process of change should mainly be rooted in the system. So this actually checklist and everything, it is from the outside, according to the culture, local culture and availability and everything. This has to be, there should be sustainability, it has to be rooted in the system. And because the sustainability is a question mark, QA should focus more on the process, so not on the target, especially because they are not adapted to the quality culture, our staffs. So they much more to achieve the target, they considered more on the target. The teamwork and coordination of the quality assurance at the facility level, at all the level. So it is very important to achieve the goals, and the need for leadership at the district level and also at the facilities level, it is necessary. And we have to integrate because there are many quality assurance in the different programs, either in malaria or other programs. So we have to integrate all the quality assurance activities under single umbrella. And in my conclusion, QA needs long-term vision, and also the culture of the quality must grow. So it requires much more time, and we have need for room for the bottom-up initiatives next to the top-down management. Okay, thank you.